Hello,
Hello.
my name is Collette Moore. I'm your student nurse practitioner, and I will be performing a HEENT examination on you today, which is your head, your eyes, your ears, your nose, and your throat examination. Can I have your name?
Yamaya Watson,
Yamaya, can I have your date of birth?
August 19th, 2002.
How old are you?
I'm 18 years old.
Okay, so I have just a couple of questions before we get started. Yamaya, do you consent that I will be recording this HEENT exam and uploading it to YouTube for my instructor?
Yes.
And do you also consent me to perform the HEENT examination on you?
Yes.
Okay, good. So before we get started, I'm just going to wash my hands. The first part of my examination will involve inspection. So I will be inspecting the head. For the head, I will be looking at the symmetry. I will be looking at the shape. I also will be following the contour, making sure that it is rounded. I am looking for any abnormal trauma. I am looking for any bruising or scoring or any lumps or anything around the head. I don't see any hematoma. I don't see any lesions. I don't see any cysts. I don't see any abnormal rashes. And I don't see any abnormal lumps or bumps around the head. Moving on to the hair. I am looking at the hair. It is evenly distributed throughout the head. It is nice and it is well groomed. I don't see any balding. I don't see any patches. I don't see any hair loss. And I'm looking at the texture. It is soft and coarse for the ethnicity of the patient. So the hair is very good. So now I will be inspecting. I will take my hand and I will be inspecting her head. So I'm going to take both hands, move around the skull into the scalp, and I'm looking for any, I am feeling for any masses, any lesions, any lumps, any bumps, any cysts, any hematoma. I'm going back to the occiput. I don't feel any depression or anything around the head. So I will say that the head is normal cephalic. Moving on, I am going to move on to the eye exam. I will be performing a visual acuity exam in which I'll be using a Snellen chart. So with the Snellen chart, I will be having the patient stand about 6 feet away. For the purpose of this video, I am not going to have the patient stand 6 feet away. I will just verbalize that the patient is 6 feet away, and I'll have her read the lowest line. So I'm going to have the patient cover her left eye. Can you read the lowest line?
LTFPH.
Okay, the patient has read the lowest line, which is 20/20 in the left eye. I will now have her cover her right eye.
LTFPH.
The patient has read the lowest line with her right eye. That is 20/20 acuity on the Snellen chart as well. I'll have her uncover both eyes and read the lowest line.
LTFPH.
Okay, that is 20/20 acuity according to the Snellen chart. This means that the patient is reading what the average person at 20 feet is reading. So that is a normal finding on the Snellen chart. I will now move on to the visual field tests, which I will be checking the visual fields. And I will be checking each eye separately for a visual field confrontation. So for this test, I'll be having the patient look at the wall first so I can dilate her pupils, and then I'll be testing her visual confrontation fields in all 6 regions. And to get started, I'm going to have the patient follow my fingers and tell me when she can visualize them and how many fingers am I holding up. So I'm going to start off with having the patient cover her left eye. Okay, and I'm going to take my fingers.
4.
Now.
4.
Okay, take my finger.
Now 4.
Okay, take my fingers.
Now 4.
Okay, so that was the left eye. I'm going to now have her cover her right eye.
Now 1. Now 1. Now 2. Now 2. Now 1. Now 3.
Okay, that was the visual field confrontation test. The patient was able to tell me how many fingers I was holding up and when she was able to visualize them in all 6 regions of her vision. Now I will perform the extraocular motion exam. So this one I will be testing cranial nerve 3, cranial nerve 4, and cranial nerve 6. Cranial nerve 3 is ocular motor. Cranial nerve 4 is the trochlear motor. And then cranial nerve 6 will be the abducent motor nerves. So in order for me to perform this test, I'm going to be using my pen light. So I'm going to have the patient look directly at my pen light without moving her head, and I'm going to ask her to follow the actions of my pen light. So I'm going to ask you to look directly at the wall first so I can dilate the pupil. Okay, and then I am going to have you cover your left eye. Without moving your head, I would like you to follow the pen light, okay? Okay, I have tested the left eye in all 6 regions. Now we'll move over to the right eye. Can you cover your right eye, please?
Yes.
Okay, can you see the pen light?
Yes.
I'm going to have you look directly at the wall first. And can you see the pen light?
Yes.
Okay, so I'm going to have you follow without moving your head, please. So. Okay, very good. Now the patient was able to follow the pen light with both her left and her right eye. That was extraocular movement with cranial nerve 3, 4, and 6. I didn't see any involuntary nickness. I did not see any involuntary moving or ticking. So I did not see any nystagmus. Now I will perform a conversion and accommodation test. So with the conversion test, I would also take the pen light. Now move it in closer to the patient's face, in which I can see if the eyes are deviating in any way. So I'm going to take the pen light. I'm going to have her stare at the wall again. And then I'm going to bring the pen light closer and closer, 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 closer. And I see the deviation of the eyes at about 6 centimeters. The normal for conversion is 6 to 10 centimeters, and the patient was right about 6 centimeters, which is normal. Now we'll do the accommodation test. Now the accommodation test, it involves, as I move the object in closer to the eyes, it will constrict, and I move it further away, it will dilate. This is called the conversion test. So I will take the pen light. Then I will move it in closer, 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 closer. I see the eyes are constricting, and as I move it further, 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 I see the eyes are dilating. That is called the accommodation test. So now I will perform the direct and consensual pen light test. This would involve me taking my pen light and shining in the patient's eye. That way I can watch the pupil as they constrict. I have a number system on my pen light, so I'll be able to see the millimeter of pupil size. Turn my light on. It is working fine, and I'm going to get started on that part of the exam. So I'm going to take this light and I'll be shining it in your eye, okay? So I will start off in the left eye. So I will take the pen light and I bring it inwards, watching the pupil as it, okay, take it out, bring it in, okay. I see that the pupil, it went from 3 centimeters to 1 centimeter, and the pupil size was 3 millimeters. Okay, gonna do it again in the other eye. Okay, so moving in. Okay, good. Out. Then move it in again, and then out. Okay. Also, I see that the pupil size also changed. So it is normal to see the pupil go from the 3 millimeters to a smaller size, and then as the light moves away, come back into the regular size. So that was 3 millimeters according to my dial. That is the normal pupil size for the patient. Now I will move on and I will perform what was next? Whew. The ophthalmic exam. So I will take my ophthalmic scope, turn the light on, make sure that it's working, and it is working fine. And I will be checking the fundus examination on the patient. I will be checking for the fundus. So I will be dimming the light, but I can't do it right now because it would make it dark. But for the purpose of the video, I am verbalizing that I am dimming the lights. And I'm coming in at a 15 degree angle to watch for the fundus examination. So as I turn this on, I'm going to start off and I'm going to look into the patient's eye. I'm going to move closer. I see the cornea, I see the lens, I see the red reflex. I'm moving in closer. I am following it down to the yellow-orange structure. I see the yellow-orange structure. I see the optic disc. The optic disc is intact. The margins are sharp. I don't see any AV nicking. I don't see any cottonwood spots. And I'm following down to the vessels. I don't see any hemorrhage. And the optic disc ratio is 1/3. Okay. And I will do the same for the other eye. Again, the light is nice and rounded so I can be able to visualize. And I am going to start, I'm going to take my right hand and I'm going to look at the patient's right eye. Let me do that again. So this is right eye over there, right? So I'm going to look at the right eye again. I am going to be following in. I see the cornea, I see the lens. I see the red reflex. Following the red reflex, I see the yellow-orange structure. I am locating the optic disc. I see the optic disc. The optic disc, the margins are sharp and it's intact. I don't see any AV nicking. I don't see any cottonwood spots. And I visualize the vessels. The ratio on the optic disc is 1/3. And the vessels, there no hemorrhage noted. Okay. Now I am going to take my left hand and I am going to look at the patient's left eye. Use my hand. I'm going to brace it for safety so we don't bump into each other. Again, turn the light on. Coming in at a 15 degree angle. Your eye open. I see the cornea. I see the lens. I am following in. I see the red reflex. Following the red reflex, I see the yellow-orange structure. Following it in, I see the optic disc. The optic disc is intact. The margins are sharp. I don't see any AV nicking. I don't see any cottonwood spots. I am following it down to the vessels. I don't see any hemorrhaging. The optic disc ratio is 1/3. Okay, and that concludes our part of the eye examination. I am going to move over to the mouth, the throat, and the face. I'm looking at the face. The color is even. The symmetry is good. I'm looking at the eyebrows. They're even. I'm looking at the pupils. They're equal. I'm looking at the eyelashes. They're pointed outward. There's no inward eyelashes in. I am going to pull up on the eyebrows. Have the patient look up. I'm looking at the sclera. It is nice and white. I'm going to come down. I am going to look at the conjunctiva. It is nice and pink and moist. I see the lacrimal system. I don't see any excessive tearing. I see the iris and I see the cornea. I don't see any opacities. Okay, I'm going to palpate the sinuses. So I'm going to take my hand and I'm going to palpate the frontal. Do you feel any pain or tenderness when I feel on these?
No.
Okay, now I'm going to do the maxillary sinuses. Do you feel any pain or tenderness when I feel on these?
No.
Okay, so I was checking for TMJ. The patient doesn't feel any pain or tenderness. So I am going to move over into the mouth. Okay, I will be using my pen light for this part of the exam so I can have some type of light source. But first I will be inspecting her mouth and her lips. I'm looking at her lips. I don't see any chafing. I don't see any crusting. I don't see any lesions. It's nice and moist. It's not dry. She has lip gloss on, of course. So her lips are normal. I don't see any hepatic rashes or any lesions around her mouth area. Okay, so I'm going to have the patient open up her mouth. I'm looking at the buccal membrane. It is nice and pink. I'm looking at the palate. It is soft, nice and pink. I am looking at the tongue. The papilla is even. The tongue is not protruding. The tongue is midline. I'm going to have the patient lift her tongue. I am looking at the submandibular, and it is nice, and the floor of the palate is connected very well to the tongue. I am looking at the teeth. I don't see any dentures. I don't see any dental caries. I don't see any missing teeth. I don't see any abscesses or signs of infection around the teeth. I am looking at the gingiva. It is nice and pink. I don't see any bleeding gums. I see all the teeth are attached to the gingiva, and I don't see any signs of infection. I don't see any hypertrophy. So I am going to have the patient open up her mouth a little bit more, and I am going to view the, have her say ah, checking cranial nerve 10 and 12, 9 and 10. I see the uvula, it is rising. I see the pharynx, it is nice and clean, no erythema. I see the tonsils, they are at grade 0. Again, the inside of the mouth is nice and clear. Now I am going to be checking the strength of the tongue. I'll be putting my gloves on here. Okay, be taking my fingers, looking at the, putting it on the palate of her tongue. And press down, ask her to push up on it, and this is good strength of resistance. Ask her to put her tongue in both sides of her mouth. Very good, very good. Now I will move over to the neck. We'll start off with some range of motion and inspection of the neck. I'm looking at the neck. I don't see any abnormal discoloration, no bulging, no bruising, no lesions, no cysts, or anything that's noticeable outside the neck. So I'm going to have you flex your neck forward. Bend it down to your chest. This will be flexion. Good. Bring it back. Then I'm going to have you hyperextend it to your back, all the way back. Very good. Bring it back. Very good. I'm going to have you look all the way over to your right shoulder. Very good. And I'm going to have you look all the way over to your left shoulders. Okay, and I am going to have you strut your shoulders up. I'm going to be checking the spinal accessory strength. So go ahead and strut your shoulders up. Okay, and don't let me press them down. Okay, this is good resistance against the shoulders. So I'm going to have you relax them back. I'm going to take my hand. Don't let me push your face. Very good. Take my other hand. Don't let me push your face. Very good. So good strength and good resistance. So now I will be palpating the lip nodes of the neck. I will start at the pre-oculicular, which is in front of the ears, the post-oculicular, which is behind the ears. I'll be palpating the submandibular. Okay, very good. The submental, very good. Then I will be palpating the pre-cervical, which is in front of the neck, and then the post-cervical, which is further down. I will also do the subclavicular, which is in between the little neck down here, and I don't palpate any masses or any abnormal lesions on the neck. So now I will move over to the ear exam. Okay, so for the ear exam, I am going to do the auditory acuity. So with the auditory acuity, I am going to whisper a couple of syllables in the patient's ear. She would not be able to see my face, and she would not be able to read my lips. This is an auditory acuity test, which is called a whisper test. So I'm going to take my hand, I'm going to block her ear, I'm going to bend over into her ear where she cannot see my lips, and I will whisper a 2-syllable word, baseball.
Baseball.
Okay, very good. I will do the same on the other side. I will take my hand where she won't be able to see my lip, and I will whisper a 2-syllable word, basketball.
Basketball.
Okay, very good. That was her whisper acuity test. So her next test I will be performing is called a Weber and Rhine test, where I'll be checking her neurosensory conduction hearing test. Okay, so for this test I will use my tuning fork. So with this I will tap my tuning fork and put it on the middle of her head and see what she can hear. Can you hear that?
Yes.
Okay. Where do you hear it?
In both ears.
All right, so the patient I indicated she can hear this in both of her ears. I am going to move on to what's called the Rhine test, which I would tap my tuning fork, put it on her mastoid bone, see what she can feel and hear. Okay. Okay, I'm going to place it on the mastoid bone. I'm going to do this on her left side. Can you feel that?
Yes.
Let me know when you cannot hear it anymore.
No.
Okay, do it also on the right side. Place the tuning fork against her mastoid bone. Can you feel that?
Yes.
Let me know when you can stop hearing it.
No.
Okay, good. The patient doesn't have any neural sensory or conduction hearing loss. So her air conduction is greater than her bone conduction, which was the hearing test. Now I will perform the ear exam. Okay. Did we finish the neck? Oh my God. So for this one, I will be looking at the external part of her ear. I'll start on this side. I'll be looking at the auricle and the pinna, and it's nice and clean. I don't see any drainage. I don't see any discharge. I'm looking at the tagonus. I think it's called the tagonus, which is on this little edge. There is no bulging. There's no redness. There's no any external discharge or anything coming out of the ear. So then I will take my ophthalmoscope and my otoscope, and then I will press it upside down, and I will brace the ear canal so that way it will not bump against the patient and injure the patient and her tympanic membrane. So for adult, I'm going to pull up and I'm going to pull back. Okay, and I'm going to turn on the light source so we can be able to see. And I have good light source. I don't really need the gloves to do that. Okay, good light source. Okay, now I am going to look in her ear. I'm going to look at the external structures. I don't see any drainage. I don't see any discharge. I don't see any redness, lesion, bulging, or any abnormality with the ear. So I'm going to follow this in. And I see the umba. I see the handle of the mellitus. I see the tympanic membrane. It is nice and pearly gray. I am going to follow it in. And I can see the cone of light. The cone is light in the right ear is at 5 o'clock. Okay. So I will do the same on the next ear. Coming over, I will be looking at the auricle and the pinna, and it's nice and clean. There's no drainage. There's no redness. There's no abnormal discharge. I'm looking at the tegus. And it is nice and rounded. There's no bulging. There's no discharge or bleeding or drainage coming from the ear. Again, I'm going to brace for safety. Have this against the ear. Going to follow the otoscope into the ear. And I'm going to have a good look here. I see the handle of the mellitus. I see the umba. I am following into the tympanic membrane. The tympanic membrane is poorly in gray. There is no sign of foreign body. There is no perforation. The tympanic membrane is poorly gray and clean, no discharges or signs of infection inside the ear. And I can see the cone of light in the left ear at 7 o'clock. Okay, so we'll move on from the ear exam. Okay, now I will move on to the thorax exam. I will inspect the thorax. So I am looking at it. I am counting the rings. I have 1, 2, 3. I feel the 3 rings of the cartilage, and I'm going to have the patient take a good swallow up and down. The isthma is moving up and down, which is a normal finding. So everything looks good on the front of the thorax. So I am going to check the thyroid. I'm going to move behind the patient to check it. Again, I'm going to have the patient do one more swallow up and down. And you can see the isthma moving up and down with no problem. I'm going to come behind the patient and I'm going to take my hand. I am going to start on the patient's left side and I'm going to push it over towards the right. I'm going to take my right hand and I'm going to palpate. I don't feel any lesion. I don't feel any mass, any abnormal findings, and I don't feel any goiters. Okay, so I'm going to do the same thing on the other side. I'm going to take my right hand and I'm going to push the thyroid by the second ring over to the left. I'm going to take my left hand and I'm going to palpate. I don't feel any masses. I don't feel any lesion. I don't feel any goiter or any abnormal findings. Okay, and this concludes our HEENT exam. Thank you very much, and thank you, Yamaya.